Um, Hello everyone. Myself Dr. Anuj, and I am going to take the Euroanatomy part. Till the last year, we take the Euroanatomy class in 7 to 8 hour class, but now as the syllabus is changed and the pattern is mainly general surgery based, so the class is very concise and it is up to the point which is important for you as a MCQ. Okay, so don't think anything is beyond your scope. Whatever I we learn in this next 2 hour is all about the important MCQ. Okay, so in this class we mainly dealing with the kidney. Okay, then we goes down to the ureters. Okay, then bladder, and then the main of the reproductive system. Okay, in this way we going to do in this class. Okay, and also the retroperitoneum, which is important for you as a general surgeon also. So am I audible to all of you?
Yes, sir.
Yes.
Okay. Okay, so we started with the kidney. As we see in the cut sections, okay, there are 330-degree angles of the kidney. Remember this thing? There are 330-degree angles. This is very important MCQ. Okay, there are 330-degree angle in the kidneys. Okay, the position of the kidney is aligned in 330-degree angles. Okay, so what are these 330-degree angles? Okay, so when we see the CT scan, okay, if we take the CT scan of the patient, we take the sagittal section. Okay, this is a sagittal section. Okay, and this is a coronal section. Okay, and one is a axial section. Okay, is is it clear? Okay, so when we take the axial section in the CT scan, we see that in the CT scan the kidney is aligned not like this, not like this. Okay, this is a cut section. This is a cut section of the kidney in the axial plane. Okay, so the kidney in the axial plane is aligned more towards the 30-degree angle. Okay, we'll talk about this later. First we go in this diagram. See this diagram first. Here it is a that we take the coronal section of the patient. Okay, it is a vertical section, and we see that the kidney is aligned with the vertical section around 30-degree. Okay, so with this the lower pole is lateral. Okay, this is a vertical section and this is a 30-degree. Okay, so first 30-degree is with the vertical plane. Then in the frontal plane, patient in lying down position. Okay, patient in lying down position, and we see that the kidney is with the frontal plane. This is a vertical plane. Okay, and this is a frontal plane. With the frontal plane also, the kidney is lying more towards the lower pole is more towards the anterior side. Okay, so lower pole is anterior, and this is the second 30-degree. Okay, now the first 30-degree is a vertical plane, second 30-degree is a frontal plane, and the last 30-degree is this one. Okay, so if the kidney is like this, as we seen in the patient is standing in front of us, and we see the patient kidney is present here. Okay, so assume that somebody touched the kidney from the lateral side. Okay, push the kidney from the lateral side. Okay, so the kidney is rotated. Okay, so the kidney is rotated toward posteriorly from the lateral side. Okay, so assume yourself that you are standing and somebody touches you from your right shoulder. Okay, so you're turning towards the right. Okay, your right shoulder turning towards the right. Similar thing happened with the kidney also. Okay, so the kidney is the lateral surface. of the kidney turns little bit posteriorly. Okay, so the angle of deviation is at the hilum. Are you getting my point? So the angle of the deviation is from the hilum. The kidney is like this normally, but it comes like this. So the lateral surface of the kidney is posterior and the angle of movement is at the hilum. Okay, so the 330-degree angles are at the hilum, so that the lateral surface is posterior. Remember this thing, important. Note it down in your copies, so that the lateral surface is posterior, the lower surface is lateral, and lower surface is also anterior. How to remember this thing is LAL, Lal. It is common surname. Okay, Lal, Lal Bal Pal also. So the lower pole is anterior and lateral. Are you getting my point? Can we proceed? Okay. Then Vinay, can you unmute the students, please?
Sir, they can unmute themselves.
Okay.
Okay.
So
We can only ask
I want
unmute.
the student to unmute themselves so that the interaction will be more casual here. Okay. And if anybody having any doubt, please let me know. So
Okay, sir.
now, okay. So this is about the angles of the kidney, and the important questions is asked about these angles several times in the exams. Okay. Now, what is there is a one bulge in the kidney in which the question is asked, that is known as dromedary hump. Okay. It is nothing. Dromedary is a name of it is the camels in the Middle East is known as dromedary, and the hump is nothing but it is a normal parenchymal bulge. Okay, so the question is asked in your exam as a MCQ. Is it a normal thing? Yes, it is a normal process. Okay, it is a normal process. What is this? This is a normal parenchymal bulge. Okay, and why it is occur? Because you feel that the kidney is like a pouch of water. Okay, and if the pouch of water is pushed from the above, it will be bulge out. Okay, if kidney is like this and the is like liver is present here, and on the left side the spleen is present. So due to the pressure of liver on the right side and due to the pressure of the spleen on the left side, the kidney is bulge out. Okay, there's a bulging of the parenchyma of the kidney. So it is normally present in around 1 to 3% of the patient, but there is no need to remember the percentage. Just remember that it is a normal process and it is due to the parenchymal bulging. Why this parenchymal bulging occurs? Due to the pressure from the liver or the spleen, and it is common on the left side. So remember these three important points about dromedary hump and write it down. Okay. Now we are dealing the kidney from outside to inside and the relation of the kidney to its surface anatomy. Okay, so in this diagram we see the kidney from behind. Okay, we see the kidney from behind. This is right kidney and this is left kidney. So we are more precise towards the MCQ in this class. Okay, we are not dealing with any surgical anatomy, and we are not going to do any lab or robotic surgery after the class. We are going to do the MCQ after the class. So we are more precise about the anatomy in view of MCQs. Okay, so what is important in this diagram as far the MCQ is concerned? So first point to remember is the normal length of the kidney. Normal length is the kidney 10 centimeter. Why it is important? Because remember this important MCQ, because in CKD patient, chronic kidney disease patient, the size of the kidney is shrunken. So the patient with the USG report or the CT report came to us with the size of kidney 6 centimeter. We assume that the kidney having some CKD changes. Okay, when one of the changes is shrunken kidney. Important point to remember that it is 10 centimeter behind. Another important point in the kidney is you already know that the right kidney, this is right, this is left. We see the patient from behind. Okay, so the right kidney is little bit lower than the left. Okay, so the right kidney, it associated only 12th rib. This is only 12th rib, while the left kidney is associated 11th rib and 12th rib both. Okay, so why it is important for us to remember? Because when we do any open surgeries, okay, when we do any open surgeries and we have to go inside the kidney, we have to do the nephrolithotomy or the pylolithotomy. So in that cases, we have to uh, go beyond the 12th rib or through the 12th rib to reach the kidney. Okay, so when we do the pylolithotomy on the 12th on the right side, we go usually either the 12th rib cutting incision or subcostal incision, while in the left side we usually go through the 11th rib cutting or in between the 12th or 11th. So remember this important point, which kidney is associated with which rib. Okay, now there are three important nerves are present in the posterior part of the kidney. What are these? Remember these important part, three important nerves. Okay, from above to downwards, the three important nerves are subcostal nerve. Okay, then the ilio-hypogastric. Write it down, all these important point. And third is ilio-inguinal nerves. Okay, so when we do the any open procedure in the kidneys, the pain or the sensations are mainly associated with the kidneys are due to the these nerves also only. So the question which is asked in your MCQ is, where in the abdominal muscles these nerves are present? In which two muscles? As you all know, in the abdomen there are three muscles are present anteriorly. What are these? External oblique muscle. Second is internal oblique, and third is transfer abdominis. Okay, so these nerves are present in between which muscle? Okay, these nerves are present in between internal oblique muscle and the transfer abdominis muscle. Okay, so remember this important MCQ. Am I clear? So we already
Yes, sir.
now the another important point which is asked as a MCQ. If we do the any renal surgery, okay, and we give the traction, if we give the traction to the kidney, there will be the bleeding at the upper part of the pole, from there bleeding from the upper pole of the kidney. And why this bleeding occur? There are several options, 1 2 3 4. So the reason behind this is that when we do any open renal surgery, and the bleeding which is occur is mainly due to the uh, due to rupture of hepatorenal on the right side and splenorenal on the left side. So when we do renal surgery, we do the traction. So it is advisable that during the renal surgery, don't give any traction to the kidney, because it will rupture the hepatorenal ligament, and which causes a very torrential bleeding is present at that point of time. So it is advisable to mobilize the kidney, not give any traction to the kidney, so that the bleeding will be the minimal. Okay, so the reason is hepatorenal ligament traction or the splenorenal ligament. Okay, so the when the question is asked which is a ligament or why the what is the cause of bleeding due to the traction of the renal kidney, is these 2 points. Now, as we mentioned previously, that the kidney is associated with left side with 11th and 12th rib, or posteriorly, and right side only 12th rib. So what is this? What is this procedure is? What we are doing here? What type of needle is this? Anybody? What is the main procedure in urology? Anybody? Please be attentive. and tell me very simple. Yeah, it is the PCNL. As general surgeon, everybody knows what is a basic urological procedure, PCNL. Okay, and what we do in the PCNL, we puncture the kidney first, and then we dilate the system over the guide wire, and we enter into the system. Okay, so what is the MCQ in this? Okay, so what is the MCQ? Remember this thing, when we do the puncture, so the ribs is associated and the pleura is also associated. Okay, this is what? This is pleura. Okay, so the question is chances of pleural injury during PCNL. If we do the subcostal puncture is best and safe. Most safe puncture is subcostal. There is only 0.5% chances of pleural injury. If we do the supra 12th, this is 12th rib. If we do a supra 12th puncture, then the chances is 5%. Important to remember this percentage. Okay, and if we do the supra 11th, the chances of pleural injury 25%. Okay, so that's why the subcostal is safe puncture, but it is not versatile puncture. It is not versatile puncture. Okay, remember these important points. Safe puncture because there is a lowest risk of pleural injury, but it is not versatile puncture. We'll discuss later why it is not versatile puncture. Okay, now till here we deal with the kidney from the outside. Okay, the dimension. Now we cut the kidney from upper part of the kidney is cut down, and we enter inside the kidney. Okay, we enter inside the kidney. So you all know that the kidney is divided into the cortex. Okay, the outer part of the every organ is usually cortex, inner part is medulla. Okay, and in kidney there is a pelvic calyceal system also. So what is pelvic calyceal system, what is cortex, and what is medulla? So when we cut down the kidney from the above surface and we enter the kidney, this is a microanatomic structure of the kidney. We see that this part, okay, this much part or this much part is what? The outer pale part is renal cortex. Okay, so what is the important MCQ about renal cortex? The cortical thickness is 1 centimeter. Okay, this is important MCQ. Why it is important? Because when there is a gross hydronephrosis or when there is a any mass is present, the kidney become non-functioning and this cortical thickness becomes very low. So the thin cortex suggestive of non-functioning kidney. Okay, so the cortical thickness is usually in the normal kidney is 1 centimeter. So what is this? This part of the kidney is medulla. Okay, this part is medulla. Okay, so what is cortex and medulla? This combination is known as parenchyma. Cortex plus medulla is known as parenchyma. Okay, in various USG report, when you see the patient in your general surgery department, in USG report they write the parenchymal thickness and parenchyma. What is parenchyma? Parenchyma is nothing but it's a combination of cortex plus medulla. Okay, so this is cortex, the outer part, and this is medulla. Okay, why this is important? Because this is the main functional unit of the kidney. Main functional unit of the kidney is the cortex plus medulla. Okay, so this medulla is made up of this medulla is made up of various pyramids. In this is whole medulla. This is medulla. Okay, so in this medulla there are multiple pyramids are present. Okay, multiple pyramids are present. These yellow things are what? These are the pyramids known as renal pyramids. Okay, so this is renal pyramids. Okay, and these renal pyramids open, and this is what? This is minor calyx. Minor calyx is a part of pelvis calyceal system. Okay, pelvis calyceal system part is minor calyx. Okay, till now this is renal pyramids. Okay, and the outer part is renal cortex. Okay, and this is mainly the base of the renal pyramid. There is mainly 8 to 10 renal pyramids is present. No need to remember now, because your exam is more like a general surgery candidate, so it's not on the basis of urology, so you are more dealing with the more concise and the more superficial way of anatomy. So just remember that the medulla, there is a one cortex, that is there is one medulla. In medulla there is a renal pyramid is present, and renal pyramid is open in the minor calyx. Okay, are you getting my point? And this renal pyramids, the junction of renal pyramids with the minor calyx. Okay, the if this is renal pyramid, okay, the apex of the renal pyramid is known as papilla, while the part of the minor calyx which receive this papilla, okay, the part of the minor calyx will receive this papilla is known as fornix. Are you getting my point? If anybody having doubt, please let me know. Hello.
Understood, sir.
Okay, so it is very clear that there is a cortex is present, medulla is present, and the medulla, from the medulla there is a renal pyramids. Renal pyramids, the apex of the renal pyramid is papillae, and it drains into the minor calyx, and the part of the outer wall of the minor calyx in which the papilla is drainage is known as fornix. Okay, these all are the important MCQ in your exam. What is renal pyramid, what is renal papillae, what is fornix, and what is minor calyx. So the minor calyx is drained into the major calyx. Okay, then it drain into the major calyx. This is the then it is all the pelvis and then into the ureter. Okay, so all clear to you. Now one important thing is that what is column of Bertini is. Okay, so we all deal with the cortex, medulla, which is pyramid. Okay, now what is column of Bertini? Column of Bertini is nothing but it is the extension of cortex. This is cortex. Okay, the cortex is extended in between the medulla. Okay, like this. In between the medulla, like this. Okay, so this is the extension of cortex in between the medulla to form the column of Bertini. There is a one important MCQ that we have to, while doing PCNL, we have to enter from this, like this, in the system, because stone are present here only in the pelvis calyceal system, not in the parenchyma. So stone are mainly present in the upper, middle, or lower kidneys in this pelvis, or either in the calyx. Okay, so it is advisable to enter the kidney during the PCNL through these calyces, these papilla only, not through the column of Bertini. Why? We'll discuss in the next slides. Okay, we already discussed this thing. One important thing I forget to that the what is difference between simple calyx, minor calyx, and what is the difference between a compound minor calyx. Okay, so just remember, we see that the medulla, okay, medulla having renal pyramids. Okay, these renal pyramids open into the minor calyx through the papillae. Okay, usually when one papilla open into one minor calyx, okay, then it is known as simple calyx. Okay, while when two or more papillas open into one, then it is known as one minor calyx, then it is known as compound calyx. Okay, so the MCQ, what is the MCQ in this? The MCQ in this is where is the rule where the compound calyx is present in the kidney. In the upper pole, it is always the compound calyx is present, while it is rare in the middle calyx. while it is common in the lower calyx. Remember this important MCQ. Okay. Now we deal with the
With the
renal vasculature.
last point regarding the compound calyx.
Compound calyx, just simple thing. When single papillae, this is pyramid. Okay, multiple pyramids. These multiple pyramids is the apex of the pyramid is known as papilla. Okay, these papilla open into the minor calyx. This is minor calyx. Okay, when single papilla open into the minor calyx, one minor papilla open into the one minor calyx is known as simple calyx. But when there is a minor calyx and two or more papilla is open here, then it is known as compound calyx. Okay. For general surgery point of view, this much is important. Why it is very important for us as a urologist? Because when we take the puncture in the kidneys and the kidneys compound calyx, having this calyx, then if it is a simple calyx, then it is very easy for us to move in the calyceal system easily. But when it is a compound calyx, we have to enter there is a little less area for the movement, so there is more chance of bleeding. Okay, are you getting my point?
The compound calyx more commonly present in upper pole, sir.
It is rule. It is always present in the upper pole. In all the upper pole calyxes, is it always a compound calyx? Okay.
Okay.
It is rare in the middle pole, but it is not rule in the lower pole, but it is common in the lower pole. Are you getting my point?
Yes, sir. Yes, sir.
Okay. Okay. So the renal vasculature. You all know what is the renal vasculature. Renal artery is mainly, sorry, renal system is mainly supplied by the renal main artery. This is the branch of aorta. You all know this thing. So what is important for you to know is that the renal artery is further divided into the further branches like anterior and the posterior one. Okay, so this is an anterior branch. Okay, this is anterior branch which supply into the apical, which is divided into the apical, upper, middle and lower segmental arteries. These are the various segmental arteries of the anterior branch of the renal artery, while the posterior segmental artery supply the posterior 1/3 of the kidney. Okay, now the important MCQ is this posterior branch is the first branch of the renal artery and it is the most constant branch. Important MCQ, remember this point. Okay, and if this posterior branch is aberrant, usually what happen? Usually this is present below the pelvis. In the kidney, the arrangement of the vein, artery and pelvis is like this. First is vein, then it is artery, and then it is pelvis. And the last is the posterior segmental artery. The last one is the posterior segmental artery. When we goes from anterior to posterior, the arrangement of the vessels and the pelvis is vein, artery, pelvis. Okay, VAP, and then the last it is posterior segmental artery. So this is important point to remember. Okay, the arrangement of the vessels and the pelvis in the renal hilum. So posterior segmental artery is present in the most posteriorly, below the behind the pelvis. Okay, but if this posterior artery is present anteriorly, okay, with this this arterial system, the anterior one. Okay, this when usually pelvis and last is the posterior segmental artery. But if it is present with this anterior branches, which we seen here, so what we call it causes PUJO. What is PUJO? PUJO is pelvic urethral junction. PUJO, PUJO, pelvic urethric junction obstruction. Okay, so one of the cause, but one of the secondary cause of pelvic ureteric junction obstruction is aberrant vessel. Aberrant vessel. Important MCQ, which is made by the posterior segmental artery. It is usually the most constant branch. This is one important First branch, most constant branch. And if it is aberrant, it causes UGO. Are you getting my point? So the most common variation seen in the renal artery is supernumerary renal arteries is the most common. There are multiple renal arteries supply the kidney, one from the renal, one from the aortas, another from also from the aorta, and some from the other branches also, like from the SMA. Okay, they supply the kidney. Now we discussed in the 2 slide back that we have to take the puncture in the kidney through this renal pyramid and enter the system through the calyx, not through the column of Bertini. Okay, not through this. Advisable is this. Why? Because as we seen previously that the renal artery is divided into the various apical, upper, middle, and lower, and posterior segmental artery. Okay, so when it goes inside the segmental artery goes inside the kidney, it entered the kidney here. Okay, are you getting this thing? This diagram is clear for you? Okay, this is nothing but this is a enlargement part of this thing. Okay, so this is minor calyx. The kidney, the renal artery, the segmental branches enter into the parenchyma of the kidney. Okay, this is a parenchyma of the kidney, and the segmental branches enter. At the level of minor calyx, this segmental artery divided into a lobar artery. Okay, lobar artery. This is an important MCQ because they are the arrangement. Which artery comes first after the segmental artery? So the segmental artery is divided into the lobar artery. Then this lobar artery is divided into the interlobar arteries. This is very important to remember. Okay, these are two interlobar arteries. This is a third division, interlobar arteries. So these interlobar arteries, due to this interlobar arteries, it is not advisable to take the puncture from the column of Bertini, because this is the column of Bertini. This is what this is renal pyramid. Okay, this is renal pyramid, and we are here. Okay, and here which vessel is lying? This is the interlobar artery, and if we take the puncture from this column of Bertini, this interlobar artery is present, which causes various very massive bleeding. Okay, so it is the interlobar artery which is the main culprit if we take the puncture of if we take the puncture from column of Bertini. Okay, or in and these arcuate arteries further interlobar artery is divided into the arcuate artery, continues as the arcuate artery, and the last branch is interlobar artery, which is continued afferent arteriole, and this is glomerulus. Okay, so remember 5 names: segmental artery divided into lobar artery divided into interlobar artery divided into arcuate, continue as a arcuate artery, then it is continued as a interlobular artery, which is continued as a afferent arteriole. Okay, are you getting my point? An important MCQ is also the interlobar artery, which is damaged during during PCNL if we do the puncture at the column of Bertini. So another important part of about